Hi, my name is Michael, and today I'll be talking about abdominal aortic aneurysms, or AAAs, and this is part of the surgical teaching series. From this talk, I'd hope you're able to define what a AAA is. I'd hope you're able to interpret some of the findings from the AAA screening program, and to recall some of the risk factors associated with AAAs. We'll be going through some cases to help us understand the symptoms and signs, and the initial management of patients with a ruptured AAA. To start off with, we'll go through some anatomy. So the abdominal aorta is a continuation of the descending thoracic aorta. And the point that the thoracic aorta penetrates the diaphragm is the level of T12 and when the abdominal aorta starts. As it continues descending, at the level of L4 is when the abdominal aorta splits into the common iliac arteries. A normal diameter for abdominal aorta is less than 2 centimeters, and a AAA is defined as an abdominal aorta which is greater than 1.5 times its diameter. So a AAA is when the diameter is greater than 3 centimeters. A AAA can also be defined in terms of its location. So you can have suprarenal AAAs, which are found above the renal arteries. You can have juxtarenal AAAs, which are found within 1 centimeter of the renal arteries here. Or you can have infrarenal, where it's below the renal arteries. And this is important to know, as it will help with surgical planning. Because in the case of, for example, suprarenal AAAs, you'd want to be able to maybe insert a stent or a graft for this aneurysm, but at the same time you want to maintain perfusion to the kidneys as well through these renal arteries. So the first case is a patient who's gone through the routine AAA screening, which is offered to all men over 65 nationally. Mr. Williams is a 66-year-old gentleman who currently has no symptoms and is feeling well on himself. He has a past medical history of hypertension, hyperlipidemia, and is a smoker. The ultrasound of his aorta shows that he has a diameter of 5 centimeters, which is fusiform in shape and involves the infrarenal portion of his aorta. Clinically, his news is unremarkable, and he has no findings on his abdominal examination, so no mass or tenderness noted. So just want you to take a moment to think about what the risk factors are that Mr. Williams has for a AAA, and can you think of any other risk factors? So in terms of risk factors, I like to split them up into non-modifiable and modifiable risk factors. In terms of modifiable, Mr. Williams has quite a few different risk factors. So he's a smoker, he has high lipids, he is hypertensive as well. Patients with a history of atherosclerosis and a history of aneurysms are also at greater risk of AAAs. Modifiable risk factors are important to know, as that might help guide some of the conservative measures you might recommend for patients with AAAs, and just generally for their general health as well. Non-modifiable risk factors include patients who are male, increasing age, or have a family history of AAAs, as well as patients who have connective tissue disorders and who have European ancestry. Interestingly, AAAs are less common in patients with diabetes. So how frequently should patients have, or should this patient have monitoring? And what sort of conservative measures would you advise for this patient? So in terms of the sort of ultrasound findings and how that determines further monitoring, so patients with less than 3 centimeter abdominal aorta haven't met the criteria for having a AAA, so they don't require further scans. Patients with a diameter of 3 to 4.4 centimeters have a small AAA and require ultrasounds every year. In the case of Mr. Williams, he has a medium AAA and will require a repeat ultrasound in 3 months. And for patients with a large AAA, so greater than 5.5 centimeters, they require a referral to the vascular surgeons. And also for patients who have a AAA greater than 4 centimeters that is rapidly growing, so that's greater than a centimeter a year, will also need a referral. In general, patients who have AAAs should be offered sort of conservative measures, and that's interventions really to support them in sort of the secondary prevention of cardiovascular disease. So for Mr. Williams, you'd offer a referral to the smoking cessation service, where they might offer further sort of education about smoking and be able to offer things like nicotine patches, nicotine gums, sprays, and further formulations which will help with smoking cessation if that is what he wants. You'd also recommend sort of weight loss and to sort of increase exercise. You get on top of his blood pressure as well, and you might consider commencing a statin and aspirin therapy. So unfortunately, 1 year later, Mr. Williams presents to the emergency department with sudden onset, severe tearing central abdominal pain radiating to his back. Started 2 hours ago whilst he was at home, and it's gotten worse. And he's been feeling sort of lightheaded, dizzy, so he's showing pre-syncopal signs. And he's had several episodes of nausea and vomiting. He's had no bowel or urinary symptoms. So this is quite a concerning history, and given his risk factors of a previous AAA that has been diagnosed on ultrasound, I'd be worried about things like a ruptured AAA. And the symptoms and signs of that are abdominal pain, sort of back pain with sort of pre-syncopal, syncopal symptoms, hemodynamic compromise, and a pulsatile abdominal mass on examination. So how would you approach this patient? So always when it's approach patients with an A to E approach, especially when they are sick. So in terms of his airway, he's patent, he's able to speak full sentences, however he's confused. His respirator O2 sats are normal, and his chest is clear. He is tachycardic and hypotensive, however, and he's got cool peripheries. He appears clammy and pale, and he's got weak peripheral pulses. He appears confused, GCS 13, and on examination of his abdomen, he's got a pulsatile tender mass in his umbilical region. Now, what would you do next? So I'd be concerned about a ruptured AAA. Obviously, you'd want to quickly rule out any other causes, but given his risk factors and his history, which is very convincing for a AAA or a ruptured AAA, I'd call for help immediately. I want him transferred to the resus, given his hemodynamic instability, for close monitoring. I'd want to notify the surgical or vascular team. In terms of further investigations, I think it'd be worthwhile to get large bore IV access, and whilst you're doing that, get him a venous blood gas with a set of blood. So full blood count, using ease, clotting, and in his case, it's important to get a group and save in particular and a cross match. By the bedside in ED, it might be worthwhile also performing a POCUS or a point of care ultrasound scan to assess his abdominal aorta. With his large bore IV access, you'd want to also fluid resuscitate him, and there is a concept called permissive hypotension, where you would aim to keep his blood pressure below 100 systolic, and really that's to reduce the amount of bleeding happening from this aneurysm, whilst also maintaining perfusion to his vital organs. You'd also consider a major hemorrhage protocol and keep him nil by mouth, as he's likely, well, he will need to go for surgical repair if this is a ruptured AAA. A CT angio is the definitive imaging modality for patients with suspected ruptured AAA. However, in patients who are unstable, it should not delay treatment. So there are two main surgical procedures that are offered to patients with a ruptured AAA, or those who have a AAA found on the screening program. So the first one is endovascular aneurysm repair, or EVAR. That's when a stent is inserted through the femoral arteries under radiological guidance, as you can see on the right here. It's usually considered for patients who have more comorbidities and for women of any age and men over 70. And the pros of this procedure is that because it's a less invasive procedure compared to open repair, it has lower perioperative mortality and it has sort of reduced length of stay for patients who've been admitted. However, EVARs are known to have a more longer-term complications requiring long-term monitoring. And so there's a 48% risk of patients having graft-related complications following an EVAR. For example, patients with an endo leak where blood leaks around the graft, and therefore require close monitoring with ultrasound at 1, 6, 12 months, and after that annually. The alternative surgical procedure is an open repair, which involves a midline laparotomy, exposing the aneurysm and clamping the aorta proximal and distally to the aneurysm. A graft is used to repair the aneurysm and is usually considered for healthier patients and men less than 70. The advantages of an open repair are that they have better longer-term outcomes. However, they are associated with more potential perioperative complications, as it is a larger and more invasive surgery compared to EVAR. Ultimately, the choice of the procedure depends on the anatomical suitability for EVARs and the patient's fitness, which will be determined by the surgeon operating.